Hello, my name is Christopher Liu, and for the last 25 years, I have been leading and providing the sole National OOKP service in Brighton. Now we're looking for a new home, and thank you for your interest. I'm going to take you through a 5 minutes video to tell you something about it. In terms of patient selection, we're dealing with very desperate patients who have been often through many operations and may be left with just one eye, the other having been lost. So basically, they have to have corneal blindness and functioning retina and optic nerve. And more often than not, the sight is counting finger or worse, and they have dry keratinized eye surface. So the indications in Brighton, the majority of cases have been Stevens-Johnson syndrome and mucous membrane pemphigoid. There are under indications, and there are, of course, contraindications as well: wet blinking eyes, unilateral blindness, those who smoke and are not prepared to give up smoking, children, those who are happily adjusted to blindness, those who are unable to comprehend the gravity of the surgical program, those unwilling to attend lifelong follow-up, or if they're unable to accept the post-OOKP appearance. Let me take you through the patient journey. First, they arrive at a multidisciplinary clinic and they see me for a very long chat, history taking, and ocular examination to ensure that the eye in question has good visual potential, and we also measure the axial length, so we know what optical cylinder power to use, and also a B-scan to make sure they haven't got any retinal detachment, and in selected cases, they will also have electrodiagnostics. Then they have their teeth x-rayed, and those are assessed by Jim Harold and Panos Koumelis, and they have oral assessment to look at their teeth, oral hygiene, state of the buccal mucous membrane, and gum and bone recession, etc. So generally speaking, it would be an OPG, although individual x-rays of canines right down to and up to the apex of the roots also acceptable. And we'd be looking at length, girth of canine tooth roots and the relationship to adjacent teeth and bone loss to determine whether there's a suitable tooth, and if there are more than one, which one is the best to go for. Then Angela Busatil, our clinical psychologist, consultant clinical psychologist, will have another long interview to make sure that they know what they are going for, and they understand the risks and are prepared to have follow-up. And very importantly, whether they have any psychiatric history and whether they are psychologically robust enough to go through the program, and also possible eventual failure of the device. They are robust enough to deal with that, and what social support they have from family and friends. So they decide on surgery and we determine that they're suitable. Then surgery is in 2 stages, or at least 2 stages, and each stage would be up to 6 hours in the GA, and they stay in the hospital for 1 week, and the 2 stages are 3 to 4 months apart, and there might be a repair of buccal mucous membrane in between the 2 stages as well, and of course they can go home between the 2 stages. Then afterwards there's lifelong quarterly follow-up and preparedness for additional procedures, be it oculoplastic, buccal mucous membrane, glaucoma, or vitreoretinal. Shared care is possible, although generally speaking, it has not been possible because there are no trained OOKP surgeons elsewhere, apart from a small number of fellows in the rest of the UK I had trained previously who can kind of look after these patients. So it's not just extracting a tooth, you've got a block of bone as well, and the root and surrounding jawbone is fashioned to a plate through which a hole is drilled through the dentine and an optical cylinder is cemented through. At the same time, a piece of skin is taken from the inside of the cheek. The eye is has the superficial scar tissue removed, and that piece of inside cheek skin is placed over the eye surface for it to acquire blood supply. So if you're lucky, then this is what happens. In the ensuing weeks, sometimes it's necessary to repair the buccal mucous membrane. And in stage 2, the tooth is retrieved from the contralateral lower lid submuscular pocket and is trimmed of excess soft tissues. The mucous membrane on the eye is reflected, corneal trephination, removal of iris, cryo-extraction of lens, vitrectomy, and then the tooth goes on the eye surface. The eye is reinflated with air. You check for centration, and the buccal mucous membrane is put back and sutured in place. And the buccal mucous membrane shrink wraps the OOKP lamina and cylinder and supplies the tooth part, sorry, the bone part, which keeps it alive. And this is what an OOKP eye looks like. So the problems that we look out for include laminar resorption, which can lead to leakage, infection, and extrusion. There can be glaucoma, and there are optical limitations, and mostly they see about 80 degrees visual field, and they all get glare, and they all wear a hat and sunglasses. Retroprosthetic membrane formation is not a big problem with the OOKP. There can be vitreoretinal complications such as vitreous hemorrhage, retinal detachment, and so on. So what requirements do we have for the new service to be commissioned at your trust? So I think it's really important to have support from your departments or your colleagues for this new service. And you need full support from the trust as well. You need to have a dedicated team, which you need to build, and you would be the dedicated leader. The hospital needs to have 24/7, 365 INE, or at least a hotline. So in case the patients are in trouble, then they can come straight away and talk to the OOKP lead. And needless to say, the OOKP lead needs to be available 24/7, 365 as well. I'm afraid even when they are on leave, otherwise who else would look after them? There needs to be inpatient beds, GA facilities, and a full range of subspecialist consultant colleagues. I will tell you more about that. And a full range of consultant physicians and access to ITU, because some of these patients have special health requirements. And of course, you need to be easy to reach by rail, air, and road. So let's have a look at the team in more specific detail. So a highly skilled and experienced team, which works well together, needless to say. Then support staff, you need an OOKP coordinator, full-time really, and you need a full-time fellow as well. Not that they cannot be doing other things, but they need to be full-time so that they are available to assist the team lead. So in terms of surgeons, then there needs to be an OOKP lead surgeon who should have a full range of skills. And although we're dealing with corneal blindness, you will see in part from the earlier part of the presentation, and also when dealing with complications, you need to be a fully trained ophthalmic surgeon, because you would be dealing with lids, mucous membrane, cornea, glaucoma, vitreous, muscle, sclera. And really, after training for the first 5 years, there should be a deputy OOKP surgeon who will be the second person, so that there is robustness in the service and succession planning as well. And this is really important. There should be 2 persons who is capable of dealing with OOKP patients at any one time. You need a maxillofacial surgeon, you need an oculoplastic surgeon, you need a glaucoma surgeon, and you need a vitreoretinal surgeon. And ideally, your units should be prepared to invest in endoscopic vitrectomy. And I can tell you when you are successful, why this is important. And you ought to have an all-day GA list, which these colleagues can co-attend as and when they're needed for particular operations. So you need a clinical psychologist, and we have Angela Busatil, who is prepared to travel 1 session a week to help with the newly commissioned service. You need clinical photography. You need 1 or 2 named anesthetists who should become familiar with this procedure. You need a named radiologist, and we have Panos Koumelis who could help remotely through a Teams meeting, at least to begin with. And really, you should have specialist nurses, named nurses, 2 in OPD, 2 on the ward, and 2 in theaters. And they're not doing OOKP all the time, but they should be the people responsible for OOKP patient care when they come through. Thank you very much for your attention. I'm happy to answer questions, and this is my email address, christopher.liu1@nhs.net, or you can contact NHS England, Nicholas Symes, and Dr. Aishi Ali. Thank you.